All right, so we have a 32-year-old G0, P0 woman who presents with dull, crampy pelvic pain that has been intermittent over the last 6 months. She is currently menstruating and notes the pain seems to worsen with menses. She also reports pain with intercourse but denies any vaginal discharge. On examination, she is in no acute distress and is afebrile. She has scant blood in the vaginal vault and no significant focal tenderness. No masses are appreciated. The pregnancy test is negative. What is the most likely diagnosis? All right, so this is a rather straightforward question. And let's just go over the answer choices real quick. We have A, endometriosis, B, middle schmers, C, pelvic inflammatory disease, and D, ruptured ovarian cyst. We've been given a gift from the question writer. There is so much rich content in this question for us to make the diagnosis, which is what we're being asked to do to find the most likely diagnosis. So let's go through this. We have crampy pelvic pain. It's intermittent over the last 6 months. So this is a chronic issue. She's currently menstruating. Good. And the pain's worse with menses. And we'll see why that's important. She also has dyspareunia and no vaginal discharge. And no vaginal discharge is, we could pair that with being afebrile, right? Which is going to be important to think about any infectious process. She has scant blood and no significant focal tenderness and no masses on exam. Okay, and she's not pregnant. Good, that's always important to know. Let's go through our answer choices. This is so rich, and we should be able to choose this answer pretty straightforwardly. So we have middle schmers. Middle schmers it's a unilateral mid-cycle pelvic pain, right? It's thought to be due to release of the egg related to ovulation. And there's no sign of, right? We have this patient's pain is worse with menses, not mid-cycle. So we could cross that out right away and be confident about that. Pelvic inflammatory disease, answer choice C, right? So for that, we're going to have fever, pelvic pain, which the patient has, but no fever. We're going to have cervical motion tenderness. We're going to have vaginal discharge. So again, we're convinced that this is clearly not pelvic inflammatory disease from the information in the vignette. And then ruptured ovarian cyst, typically this will present with acute onset. And what we've already been told here is that this patient has intermittent symptoms over the last 6 months. So right away, I can tell you that this is unlikely going to be correct. And, ruptured ovarian cyst, sometimes if it's on the right side, it could seem like torsion, it could seem like appendicitis, and that's not the picture we're getting here. So I'm going to cross out that. And that leaves us with endometriosis. And as we know, right, it's an estrogen-dependent condition where endometrial tissue develops in the extrauterine sites. Okay. And it'll be associated with dysmenorrhea and pelvic pain and dyspareunia. Everything that we see here with this patient's presentation is shouting at us that this is endometriosis. So we're going to select answer choice A. And sure enough, that is correct. Hey everyone, before you go, if you're interested in your own QBank, whether you are an MD or DO, a PA, or an MP, simply go to roshreview.com and sign up for a free trial. See if Rosh Review's content is right for you. Keep learning, keep working hard, and always have a sense of mission about your work. Now is your time. This is Dr. Adam Rosh signing off.